Question 1. A 54-year-old man with severe COPD is planned for elective intubation due to worsening hypercapnia. Which of the following best predicts difficult mask ventilation in the ICU? Malampati class 3. B. Thyromental distance less than 6 centimeters. C. Presence of beard and BMI greater than 30 kilograms per square meter. D. Limited neck extension. Poor dentition. Correct answer is C. Presence of beard and BMI greater than 30 kilograms per square meter. Explanation. Predictors of difficult mask ventilation differ from difficult laryngoscopy. Facial hair, obesity, edentulous mouth, older age, and snoring history are key. Malampati and thyromental distance predict difficult laryngoscopy, not mask ventilation. In ICU, facial seal and upper airway collapse are common challenges. Question 2. A 70-year-old septic patient with SpO2 90% on non-rebreather mask is prepared for RSI. The most effective preoxygenation strategy is 100% O2 via nasal cannula at 5 liters per minute for 3 minutes. B. 100% O2 via non-rebreather mask for 3 minutes. C. Non-invasive ventilation, NIV, with PEEP of 5 cmH2O and oxygen 100%. D. Apneic oxygenation only. Bag mask ventilation with PEEP valve during induction. Correct answer is C. Non-invasive ventilation, NIV, with PEEP of 5 cmH2O and oxygen 100%. Explanation. Critically ill patients often have poor oxygen reserves. NIV improves preoxygenation by preventing alveolar collapse and maintaining oxygenation longer during apnea. Non-rebreather mask provides less effective alveolar recruitment. Apneic oxygenation alone is insufficient for preoxygenation. Question 3. During RSI in septic shock, the induction agent that least increases mortality and provides hemodynamic stability is propofol. B. Etomidate. C. Ketamine. D. Thiopentone. E. Midazolam. Correct answer is B. Etomidate. Explanation. The induction agent for rapid sequence intubation, RSI, in septic shock that provides the best hemodynamic stability while having no proven increase in mortality from a single dose is etomidate. While it does cause transient adrenal suppression, multiple meta-analyses and studies have not consistently demonstrated an increase in all-cause mortality from a single bolus dose in septic patients. Ketamine also provides hemodynamic stability and a viable alternative, and some evidence suggests similar outcomes to etomidate, but some studies have also found it can lead to hemodynamic instability in catecholamine-depleted patients or be associated with higher mortality rates. Propofol and thiopentone cause hypotension. Midazolam has slower onset and unpredictable effects in unstable patients. Question 4. Which of the following statements about neuromuscular blocking agents in RSI is most accurate? Rocuronium has faster onset than succinylcholine at standard doses. B. Succinylcholine is contraindicated in septic shock. C. Rocuronium can be reversed immediately with sugammadex. D. Cisatracurium is ideal for RSI due to rapid onset. Avecuronium is preferred for short procedures. Correct answer is C. Rocuronium can be reversed immediately with sugammadex. Explanation. At high dose, 1.2 mg per kilogram, rocuronium has onset similar to succinylcholine but longer duration. Sugammadex reverses rocuronium rapidly if needed. Succinylcholine contraindicated in burns, neuromuscular disease, hyperkalemia risk, but not septic shock per SE. Cisatracurium has slow onset and is used for maintenance, not RSI. Question 5. Regarding management of a known difficult airway in ICU, which is most appropriate? Awake fiber optic intubation should always be done under deep sedation. B. RSI with cricoid pressure is safest. C. Preoxygenation with NIV and awake intubation are preferred. D. Immediate tracheostomy under local anesthesia is mandatory. Intubation attempts should exceed 3 before alternate approach. Correct answer is C. Preoxygenation with NIV and awake intubation are preferred. Explanation. Awake intubation preserves spontaneous breathing and airway tone, reducing risk of desaturation and can't intubate, can't ventilate events. NIV improves preoxygenation. RSI should be avoided in predicted difficult airways without backup plan. Limit attempts to less than or equal to 3 before alternate approach. Question 6. In mechanically ventilated septic shock patients, which sedative analgesic strategy is associated with better outcomes? Deep sedation with benzodiazepine. B. Propofol-based deep sedation with daily interruption. C. Light sedation using dexmedetomidine and opioid analgesia. D. Midazolam infusion without interruption. Ketamine alone for analgesia. Correct answer is C. Light sedation using dexmedetomidine and opioid analgesia. Explanation. Evidence favors light sedation for faster weaning, reduced delirium, and improved survival. Dexmedetomidine provides sedation and some analgesia without respiratory depression. Benzodiazepines increase delirium risk. Daily interruption beneficial but deep sedation still harmful. Question 7. A patient on propofol infusion for mechanical ventilation should be titrated to maintain a Richmond agitation sedation scale of -5 to -4. B. -3 to -2. C. 0. D. +1 to +2. Variable, no need for scoring in ICU. Correct answer is B. -3 to -2. Explanation. Light to moderate sedation, RASS -2 to -3, is recommended for most ICU patients. Deep sedation, -5 to -4, is reserved for refractory hypoxemia or raised ICP. Current guidelines for most patients recommend a goal of -1 to 0 light sedation, which allows patients to be awake, comfortable, and able to interact with their environment. Sedation scoring improves outcomes and reduces drug exposure. Question 8. Which statement is true regarding use of neuromuscular blockade in ARDS? Should be started for all patients of ARDS. Short-term use, less than 48 hour, may improve oxygenation in severe ARDS. C. Increases ventilator-induced lung injury risk. D. Preferred agent is vecuronium for renal safety. Prevents need for sedation. Correct answer is B. Short-term use, less than 48 hour, may improve oxygenation in severe ARDS. Explanation. Current guidelines do not support the routine or universal use of NMBAs for all ARDS patients, but rather in specific cases of severe ARDS, often defined by a partial pressure of O2 to FiO2 ratio much lower, e.g., less than 150 mm of mercury, or less than 100 mm of mercury, especially when deep sedation and protective ventilation strategies fail or prone positioning is used. Long-term paralysis risks ICU-acquired weakness. Deep sedation is required during paralysis. Question 9. In an ICU patient requiring sedation for mechanical ventilation, the analgesia-first approach implies giving benzodiazepine before opioids. B. Prioritizing pain control before adding sedatives. C. Avoiding opioids to prevent hypotension. D. Continuous infusion of propofol as first step. E. Only opioid medication for pain and sedation. Correct answer is B. Prioritizing pain control before adding sedatives. Explanation. Analgesia-first or analgosedation uses opioids to relieve discomfort before sedatives are added, reducing delirium and duration of ventilation. Commonly morphine, fentanyl, or remifentanil are used, then light sedative, propofol or dexmedetomidine, titrated as needed. Question 10. A 56-year-old male with severe traumatic brain injury undergoes a percutaneous tracheostomy after 10 days of mechanical ventilation. 2 days later, he suddenly develops massive bleeding from the tracheostomy site associated with desaturation and hypotension. Which of the following is the most likely cause of this complication? Tracheonominate artery fistula. B. Erosion of the posterior tracheal wall into the esophagus. C. Granulation tissue bleeding at the stoma site. Accidental decannulation with tracheal collapse. Tracheomalacia due to high cuff pressure. Correct answer is E. Tracheonominate artery fistula. Explanation. Tracheonominate artery fistula is a rare but catastrophic late complication of tracheostomy, typically occurring 3 days to 6 weeks after the procedure. It results from erosion of the tracheostomy tube or cuff into the innominate artery, usually due to high cuff pressure, low tracheostomy placement, or excessive neck movement. Clinical presentation: sudden, massive bleeding at the tracheostomy site, often preceded by a sentinel bleed.